everyone. I am Sana Al-Khatib. I'm an electrophysiologist at Duke University in Durham, North Carolina. And I had the pleasure of co-moderating a late-breaking clinical trial session this afternoon at the AHA Scientific Sessions. The session was titled Dilemmas in Antithrombotic Therapy, NAF Care Post-Procedures. I am delighted to be joined by Dr. Jung-Sun Kim, who is the PI of the ADAPT AF-DES trial, and he was the one who presented the results to us this afternoon. Dr. Kim, welcome.
Oh, thanks for having me here.
So Dr. Kim, please tell us about the results of the trial, just a quick summary for our audience.
Oh yeah, this trial is a randomized clinical trial. It's just enrolled 960 patients, randomized 1-to-1 ratio, either monotherapy with a NOAC versus NOAC plus clopidogrel combination therapy. Yeah. So main result is we checked the NACE, net adverse clinical event, at 12 months. So at 12 months, NACE was significantly lower in NOAC monotherapy compared to the combination therapy.
Okay. And you also reported on the risk of bleeding in that trial. Can you please share those results with our audience?
Yeah, that's right. So I think the NACE is mainly driven by reduction of NACE is mainly driven by a marked reduction of bleeding. So bleeding event occurred 13.2 in combination therapy and 5.2 in NOAC monotherapy group. So that hazard ratio was 0.38, so which is a quite significant, statistically significant finding.
So for our clinicians who are listening to us, what is the take-home message?
So I think it's very important message because previous trial has some limitation to extend the patient with a drug-eluting stent. So I think we include all patients with a drug-eluting stents in this trial, and especially expand to that kinds of population. Just a NOAC monotherapy is safer and simpler treatment option compared to the combination therapy.
So at what point when patients undergo PCI, patients with atrial fibrillation undergo PCI, and let's say PCI is being done for like patients with chronic stable coronary artery disease,
right,
not in the setting of an ACS. Yeah. What do you tell our clinicians here in terms of when they can change their patients from dual therapy to monotherapy?
Oh, actually, in this trial, just enroll the patient after at least 12 months. Mm-hmm. Yeah, implantation of drug-eluting stents. That means after 1 year, at least 1 year, I think we can recommend safely just de-escalating, yeah, with NOAC plus clopidogrel to the just a NOAC, yeah, monotherapy. So,
are there any potential exceptions to that? Yeah. Based on the data that you have seen, are there any potential exceptions to that? Like if clinicians, do you think that people should be stopping dual therapy at 12 months in all of their patients? Or are there certain patient groups or subgroups in whom that may not be the right move?
So I think it's a very important question, especially in the viewpoint of the interventionist. So actually we do the very different type of intervention. For example, in this trial, we also checked some complex PCI feature, so which observed around 26% of the population. Mm-hmm. So that means I think we need more data, especially for these patient with complex PCI with the drug-eluting stents. So I think it's very important that kinds of situations, for example, left main stenting or bifurcation with two stenting, very long stenting, very complex procedure. I think we have to do more data and personalized, yeah, to give some kinds of, apply the kinds of some strategy. So I think that means that kinds of population with a very high ischemic risk, I think we may need more extend the combination therapy with clopidogrel and NOAC.
And that highlights the importance of practicing individualized and personalized medicine, that it's not one size fits all, but perhaps for the majority of patients who did not have complex PCI, considering stopping the dual therapy after a year after the PCI, seems like is a really safe and reasonable approach.
Yeah, that's the reason why we also started another trial recently. So just include patients with complex PCI and peripheral artery disease and coronary artery disease. So I think this is another some population who need antiplatelet therapy.
Great, and we'll look forward to hearing the results of that trial as well. Well, Dr. Kim, thank you so much for being with us for this session, and thank you very much for listening.